Hello, and welcome to today's presentation on shoulder pain. My name is Karen Caffenteris. I'm the Associate State Director for AARP here in Michigan. And today we are very excited about our presentation. We're going to be joined in a little bit by the presenter who you saw back in March when he did a presentation on back pain. First, a couple of housekeeping things. If you want to ask a question, please do so by placing your question in the chat area there on Facebook or YouTube. And we will get back to you, or we'll answer the questions at the end. If you're having technical trouble, please, you can put that in the comment section also, and we'll try to troubleshoot with you also. Now, today's presentation, like I said, we'll answer all the questions at the end. So let's go ahead and bring on our presenter, Matt McFadden. And I'll tell you a little bit about Matt. Matt is Clinic Director at Peak Performance Physical Therapy. He earned his Bachelor of Science in Health Fitness and his Master of Science in Physical Therapy from Central Michigan University. He is also a graduate of the Oakland University Orthopedic Manual Therapy Program and a clinical instructor for the Michigan State University Kinesiology Program. Matt has 12 years of experience treating patients with orthopedic conditions, and he specializes in treating the spine, shoulder, and knee. Matt is a member of the American Physical Therapy Association, Sports Physical Therapy Section, and the Michigan Physical Therapy Association. Matt enjoys helping people of all ages return to what they love to do, whether it be playing competitive sports or playing with their grandkids. In his free time, he enjoys being outdoors during summer and spending his time with his wife and daughter. And summer is my favorite time too. I don't like being outside so much in the winter.
For sure.
So welcome, Matt. We'll let you get right to it so we have plenty of time at the end for questions because I know there'll be lots.
Sure. Thank you, Karen.
You're welcome.
So welcome, everybody. Thank you guys all for taking the time to come and listen to this presentation. I had good response when I did the presentation on back pain, and not far behind back pain is shoulder pain, and that kind of one of the most common areas that people have problem with sometime in their life. Most people have some sort of shoulder issue at some point in their life, and so having some ideas on how to manage that is super helpful. So what do I hope to get out of this presentation for everyone that's attending? Learn some of the common causes of shoulder pain, and then maybe learn what activities maybe predispose you or could lead to some of the things where you could be hurting your shoulder so that you can be proactive as you can in regards to preventing shoulder injuries. And then if you do have shoulder pain, what are some of your treatment options? So those are the objectives for kind of today, and we'll kind of keep moving forward into the presentation. As Karen said, that's my background. I've spent a lot of time working with shoulder and back and neck pain patients, and I really enjoy it because there's a lot, at least in therapy, on what I do, making a difference. Because there's a lot of muscles and things that are connected to the shoulder, and so there's a lot of adjustments you can make into the shoulder. So we'll kind of keep moving forward to the next slide. So I'm posing this question. You guys can put some, comments out there and we can talk later, but I'm assuming a lot of you guys that are listening have some shoulder pain. So if you do, you can kind of put out there in the comments. And then secondarily, if you are having pain, what kind of symptoms are you having, right? Does your shoulder hurt when you are lifting overhead? Do you get, a popping in your shoulder? Do you get kind of the grinding or the crepitus, like the noises when you move your arm? And those are some of the things that can better help guide, as you're listening to this presentation, maybe what some of the common symptoms are. So, and then again, I can address, general questions at the end on some of those things, but I'm just kind of getting an idea of all the people that are listening in. What are some of the issues that they're having? So we talk about, there's obviously more than this list of 4 things I'm going to discuss, but the top 4 things that we tend to see for what's causing pain in the shoulder, number 1 are probably the first 2 up there. People call it the rotator cuff. They call it other different names, but it's the rotator cuff. It's a group of 4 muscles that go over the front, top, and the back side of the shoulder that basically help keep the ball centered in the socket as you do arm motions. And so we see a lot of people that have rotator cuff tendonitis, or some actually have a tear in the rotator cuff, and everyone knows somebody who has had a rotator cuff repair surgery, right? It's pretty high prevalence. The other two things that are top of the list is people have a labral tear. And so a labral tear it's a kind of a structure in the shoulder that kind of deepens the socket. You have one in your hip and you have one in your shoulder as well. And so that can get torn. And so that can be pretty painful as well. And sometimes can be managed conservatively, and sometimes it needs a more aggressive treatment, such as surgery. And osteoarthritis, as the shoulder gets more arthritic, you may or may not know somebody who's had a total shoulder replacement. It is much more common now than it was 20 or 30 years ago, but just like they have knee replacements, if the osteoarthritis gets bad enough, people will get a shoulder replacement. And there's two different versions of the way that can be done. So those are the top causes. So I wanted to go over a few of the activities that could, bring on some of the shoulder pain. Nobody wants to fall, but a fall in an outstretched arm is one of the common ways where you get your shoulder jammed, or you do something if you are fortunate enough not to break a bone or something like that. So obviously we want to be avoiding those things, but those are some of the things that if you fall and you got a lot of shoulder pain, you probably should get that checked out. But that's one of the common causes. This could be we reach our arm out to stop us from falling. The overhead stuff, reaching overhead or reaching out to the side, those are just tough things for the shoulder. Everything gets kind of jammed up together. If you've had a shoulder problem, you might have heard the word impingement, where things get kind of pushed together. And if you have a tissue that would be bruised or injured and you pressed on it, it hurt a little bit. Well, if that tissue wasn't bruised and you were to put pressure on it, it wouldn't cause you much trouble. So when you reach overhead, a lot of tissues, everybody has impingement. It's just whether or not it actually hurts. So when you reach your arm overhead, as in that picture on the right, the tendons of the rotator cuff are being jammed up under some of the bones in the shoulder. And so if they're not irritated, it doesn't bother you. But you can see in that picture, there's compensation of how that person's reaching overhead. The head's bending to the side. They can't quite get all the motion there, probably in their ball and socket joint. And so when you try to reach and do things with all that cheating and compensation, you're setting yourself up for a lot of challenges. And so if you don't have that motion in your shoulder, you're trying to do things kind of at the end range, you're more likely to irritate the shoulder. And the other word in that description is repetitive, right? Once or twice probably isn't too bad, but I mean, it seems silly enough. You don't think it's too hard, but if you painted a room and you were doing brush strokes or you were running a roller, it's a bunch of up and down. It's more than you're used to doing. And if you don't have good control and good strength, that could lead to a rotator cuff tendonitis. So the bottom picture there, let's go back a slide. The bottom picture there shows, reaching with a fully extended arm and also reaching to the backseat of the car. Two of the no-nos, like you would say, hey, I'm reaching the backseat of my car. I'm not reaching overhead. That shouldn't be too big of a deal, right? Like I can carry a suitcase down on my side and that's okay, even if I have shoulder pain sometimes. But the issue is when you're reaching to the backseat of a car and then you go to lift, you have your arm usually fully outstretched or in one of the extremes of positions. And it's always more susceptible to an injury when it's at the extreme. So I've seen countless patients that aggravated their rotator cuff when they were trying to lift a bag or reach for something in the backseat of their car, or they reached back to do something with their kids or the passion that was back there, or they wanted to store their purse there or their something else because they wanted to be out of the way where people couldn't see it. And so I would advise you not to necessarily be storing your purse in the backseat of the car, because if you're reaching back there, your shoulder's in a compromised position. And when you try to lift with that, especially with your full arm fully extended, it creates a lot of torque on your shoulder. And so if you can't control that, that's where you could be getting a rotator cuff tendonitis. And I've seen people actually tear the rotator cuff doing it. It doesn't have to be 10-pound thing that you're lifting, to hurt your shoulder and your tendons, your muscles. It can be just the position with a lightweight that can actually cause some issues. So those would be some of the things to be on the lookout for or try to avoid, right? Falling, try to turn onto your side, right? Would be one way to do it instead of putting your arm out. Be careful if you're feeling stiff overhead with reaching high overhead. Be careful when your arm's fully extended. Even imagine if you reached across the table with your arm fully extended and lift up a gallon of milk. Well, that's a tough thing for the shoulder to do. And so, even that isn't overhead, but it could still aggravate your shoulder. So again, it's a good idea. Some of you might know what this is, but what is the rotator cuff, right? The picture on the right there kind of shows a group of 4 muscles. The shoulder blade there on the left shows the front side, and the front side of the shoulder blade, there's a muscle called the subscapularis that kind of controls the part of the front. And on the picture on the right shows the top one called the supraspinatus, and then a couple of the ones in the back. The top one is the one it's most torn. And that one helps you reach out to the side, which is what most people have trouble with. They reach out to the side and you'll see them hike their shoulder like this. They can't keep their shoulder down as they reach out to the side. And that's usually a pretty good sign that they have an issue going on with their top rotator cuff muscle. Like I mentioned before, what's the function of the rotator cuff? What does it actually do? Well, it does help you reach your arm out to the side. It can also help you turn your arm out and turn in. Hence, rotator cuff. It helps you do some rotation as its actions of some of those muscles. But in general, it's lightly kicking in all those muscles together to keep the ball centered in the socket. And so to have a better visual imagery of that, I think it's good to think about a golf ball and a tee. So in the ball and socket part of the shoulder, we have a big ball and a small socket. And that allows us to reach our shoulder in all these different directions. And our shoulder is our most mobile joint in our body. But it's able to do that because the socket is smaller. Whereas in the hip, the socket is much bigger and much deeper. And so we can't go quite as far with some of the hip motions. And so that's why we need that rotator cuff to keep the ball centered in the socket when you're reaching forward or out to the side or twisting and turning through your shoulder. And if that becomes altered, then the ball starts to shoot up or shoot forward in the socket, and that can lead to a bunch of other irritations. So it really is important that we work the rotator cuff muscles, that they stay strong. And then if you have a problem with one of them, that can lead to a lot of other issues, whether it's pain or range of motion problems or that type of thing. So kind of this rolls right into, well, what happens when we strain it, right? If we strain it without actually tearing it, this picture on the left is showing kind of the arm going out to the side. Well, as you can see, that top bone right above the kind of red piece, which is the muscle there, as it goes up, there's a bursa as well, right in between the bone above it and the rotator cuff tendon. And so if there's some irritation there and that gets inflamed and that keeps jamming on or keeps hitting that bone above it, well, then it's also pushing on that bursa and that becomes further inflamed. And both of those things, it's pretty much impossible to have a rotator cuff strain without a little bit of bursitis. And that's why a lot of times people use some anti-inflammatories to help control some of the pain. And again, the strains often occur when you're doing a lot of repetitive lifting overhead or out to the side, because that's what that top one really works and helps you do. It helps you reach out to the side and reach overhead. And so if you're having that, what kind of things would you be expecting to see? Probably you might be able to reach forward okay. You might be able to reach behind your back okay. But if you reach out to the side, that's where it really starts to hurt. So the next thing, well, what is a rotator cuff tear? This picture demonstrates it pretty well. And it shows there's actually a partial tearing in the muscle. Now, some people do fully tear the whole tendon, right? So the muscle turns into the tendon and the tendon attaches to the bone. And so if you get a tear in that, a lot of times, a lot of people have a partial tear, but you can also have a full thickness tear. And so the picture on the top shows a full thickness to the full length of the tendon, right? It has it be torn versus just a part of it. And then again, that top one is the most commonly torn one. People do tear their front rotator cuff muscle, and they do tear sometimes in the back. And whenever there's a tear of two of them, it really is a problem, because you really struggle at any bit of reaching over your head if you have a tear or two of them. But there's a lot of people out there that if they even did an MRI on asymptomatic people that don't have any shoulder pain, might show that they have a partial rotator cuff tear. What that tells us is that it's possible to function even with, a partial tear. And a lot of times when somebody initially injures it, that's why conservative care with like physical therapy can actually work, where it's not like, oh, I tore it, I got to have surgery. And the tears can occur on the top side of the tendon or the bottom side of the tendon. And sometimes if they're doing a lot of overhead lifting and the mechanics are poor, that can rub a lot, almost like it's like, rubbing think about it like a rope, and you're kind of rubbing on it. Well, it could start breaking it down. And so, that's why when someone comes to therapy, we assess how well can the shoulder move? Can you move your shoulder blade appropriately? Those are all things that will potentially can be improved. We sit in front of a computer. We have, a slouched posture. We have our shoulder blades come forward. Those things all can dictate poor movement patterns in the shoulder. And those things can lead to some of these things like a rotator cuff strain. And if that's happening routinely, that can be more what precipitates a rotator cuff tear. So like the bottom point there says, if we can control the motion and we can limit that excessive kind of impingement or jamming together, we can hopefully decrease some of the likelihoods that you could be getting a tear. So again, being proactive, we tend to still live in a healthcare state where we react. We don't do anything until we have pain, or until there's a 5-alarm fire going off in our shoulder that says, oh, I got to see the doctor now. And so, if you've had a little bit of a shoulder problem in the past, or, it's stiff and tight and, hasn't got to the point where I have tons of pain, I would encourage you to be proactive about it. Get it assessed by someone like a physical therapist like myself, or your physician. Be like, doc, it's not bothering me that bad, but I want to make sure it does it, and maybe there are some, stretching and some other things you can do so that the strain, a strain a couple of years ago doesn't lead into a rotator cuff tear a year from now. Because, if you've had a little bit of shoulder history or you've got a lot of stiffness in your shoulder, you might be a little more susceptible to that. Now, on the other hand, if you actually have a ton of mobility, like you're really a loose jointed person, it can be tough to control the ball centered in the socket. So you're also susceptible there. If you're really loose, if you are, you can bend your arm in all different directions. You also then need to be, it's really important that you have the strength and the stability to control that. And that will be something that having the strength of that rotator cuff, which, again, if you know anybody who's had a rotator cuff tear or sprain and talk to them about it, they probably told you about how they were doing rotator cuff exercises. That's why we give those out, because as those get a little stronger, they can do a better job of controlling the ball in the socket, and less likely that somebody would tear their rotator cuff. So like I mentioned that, not everyone necessarily with a rotator cuff tear has symptoms, but the other question is how likely am I to get a rotator cuff tear? And so this is some statistics from one study that showed that 22% of people had a full thickness rotator cuff tear, which is that one that kind of goes through the whole length of the tendon. And age does have a factor in how people have rotator cuff tears. Typically, it's pretty good when you're younger, as you can see, right? The incidence increases substantially when you get into your 70s and 80s, right? Almost 11% in the 50s. 15% in people who are in their 60s, 26% there in the 70s, and upwards of 40% in the 80s. Now, this is from a sample as well that can vary a little bit, but it just shows you that in general, we have some age-related degenerative change probably to the tendon as well, so it's more likely to tear. Doing the same things you did when you were 50 versus if you did them when you were 80. So more reason to be, make educated choices on some of the things you're doing with your shoulder. Quick jerky motions are always harder. And this information also shows that symptomatic rotator cuff tears, meaning where you actually had pain, only accounted for 35% of the tears, whereas people had asymptomatic tears shown on an MRI or ultrasound, and they didn't have pain. So that shows you that even if you have a little bit of a tear, that you can hopefully get to potentially a pain-free state and still be functioning with your shoulder. Let's go on to the next slide. So now we're going to move a little bit over to the labrum. And again, you know, these pictures hopefully help a little bit. But the labrum is the rim of the socket, right? So imagine that tee again, the golf ball in the tee example. Well, if you put a little bit of like a washer on the outside of that head of the tee and made it wider so that a bigger ball could sit on it, that's what it does. It just widens it. It's like a fibrocartilaginous structure. And the labrum also has one of the tendons of the biceps that goes in and attaches to it. So that picture on the right there shows the biceps long head, and that goes up and attaches into the top of the labrum. And so that's pulling and tugging on that insertion point. And a lot of times when people have a labral tear, that's the place they get a tear. And if you had that, they call it a slap tear. That just defines as where the tear is. But and it can pull that off. Like you see in the picture, you can see it's kind of tearing there, but you can have a tear anywhere around that labrum where it attaches. And that's going to lead to a less sense of stability. And you might get clicking and popping, or you go to a certain thing and it kind of catches on you, or where it like feels like it shifts on you. The pain typically from a labral tear is a little more in the front of your shoulder, right? So the rotator cuff tear is usually a little more right on the outside of your shoulder, and run down kind of towards your elbow. The labral tears, depending on the location, again, if they're a slap tear that's torn more on the top, then typically it's a little more in the front achiness, but you can also have a posterior labral tear, and that pain is actually usually referred, and you feel it in the back side of your shoulder more. And again, to differentiate, shoulder pain usually just refers, if it does refer, it's down the outside of the arm, and it doesn't go past your elbow. So if any of you out there are saying I got shoulder pain, but I'm also having pain that goes past my elbow into my fingers or my hand, or I got numbness and tingling with it, then it might be more than just your shoulder. There may be something else going on with the nerve irritability or something else. But it's good to know that generally shoulder pain is in your shoulder. It might refer up towards your neck a little bit, and it might refer down towards your elbow, but it usually doesn't go past the elbow. And so, if people have a tear in their labrum, again, we'll show some data here that we get degenerative labral tears. So let's go to the next slide. So just kind of like we talked about, how likely are you to get a rotator cuff tear? Well, how likely are you to get a labral tear? And again, this is kind of just showing one study that used MRI, which shows all the soft tissue structures in the MRI, and they look for people that had labral tears. And patients were significantly more likely to have the slap tear, labral tears, if they were aged 51 to 65 years, and there was a likelihood ratio of 66%. And if they were older than 65, the likelihood was 81%. So again, what does this information tell us? It tells us that, again, we have degenerative tearing sometimes of the labrum. It doesn't necessarily mean there's it's a flap of a piece that's hanging up that gets caught every time, but we can have some degenerative labral tears as we get older. It doesn't necessarily mean that's a death sentence. It doesn't mean you can't use your shoulder. It just means that there's a good chance that the stability of your shoulder gets a little worse over time because you probably have a degenerative labral tear. It's more in the younger population of, let's say, throwers and things that we might see that are playing baseball and they get a labral tear. It affects some of the stuff they're doing because they're trying to throw a baseball or do something like that, and they can't get in some of those other positions. And a lot of times they need to be repaired, but you won't see someone typically in their late 50s and 60s or into their 70s getting their labrum repaired because it's usually a degenerative labral tear. So it depends on what type of tear you're having, and that can be diagnosed via the MRI. But there probably are many of you right now that have some degree of a degenerative labral tear in your shoulder right now, and it might not affect you or give you pain and that type of thing. But again, younger people, when they have a tear, that's a big problem. So the other fourth thing that I had on that list was the shoulder arthritis. And this is a good little diagram. We have normal, people always, I think about the knee as well, right? You get bone on bone. Well, you can get, it's not a weight-bearing surface like it is in your knees, but the shoulder still gets a lot of use, and you can get some degenerative change where you wear off the cartilage off the end of the bone, and you get more of that bone on bone, or where you get those points where the cartilage doesn't have any nerve endings. So it doesn't hurt when it slides and glides and moves. But when you get down to the bone, there's millions of free nerve endings. And so that's when it can hurt, right? When we get the bone on bone, you might get some spurring, you might get some other things. And the people that, if anybody answered to say that they get a lot of that grinding, that noises, that's usually a good sign that you've got some osteoarthritis, because it doesn't move smoothly anymore. And that the cartilage allows things to move and glide smoothly, and your shoulder's got to glide well for it to function well. So the next slide is going to show you a couple x-rays, right? So this just shows the bones in the x-rays. You can see that in the picture image on the left, there's some good space between the ball and the socket. And that means there's a good amount of cartilage left over and things are okay. In the middle picture, it shows some advanced osteoarthritis, because you'll lose that space in between. Like, you don't really see any space in between. Space meaning you can see that there's a little bit of the black on the picture on the left between the two bones. And then if it gets really bad in the arthritis, a total joint replacement, I think the best way to think about it is actually a joint resurfacing procedure. That's really what it is, right? Yes, they resurface, they put some hardware in, but they're resurfacing the ball and they're resurfacing the socket, because that's where the pain's coming from. Now, some people have to have a total shoulder replacement if they have multiple complete tears that aren't able to be fixed to the rotator cuff. If that's the case, sometimes they actually have what's called reverse total shoulder, where the ball and the socket, one's concave, one's convex. They actually change that around. And so depending on the functionality and how well the rotator cuff is, if somebody needs a total shoulder replacement, that's what's dictated in the type of surgery that's performed, whether it's a reverse total shoulder or whether it's just a total shoulder replacement. So where I come in as a physical therapist is I'm, one of the options, right? For people who choose to do something about it. Some people, like I said, can ignore it. And like I mentioned earlier, I think if you have a history of it, I think, if you have a little bit of aches and pains in it, it's good to get at least assessed, right? Because you can ignore it, but then it might turn from a strain to a tear. You can just live with it, which a lot of people do. And if it's been assessed and been diagnosed, well, there might be some aches and pains you still have to live with and deal with. But hopefully you do something to try to take care of it, right? At least address what issues you have, right? Do you have some strength issues? Do I actually have, a tear? Does somebody think I just have a tendonitis versus a tear? What are my treatment options? And then what can I do to be keeping it under control so that you can live, as vibrant quality of life that you want to live, and not feel like, well, I can't use my let's say it's my right arm. Well, the problem is you end up using your left arm for everything, and your left one can have troubles too. And then you're in a pickle if you can't use either arm for stuff. So I would always encourage people to be proactive and do something to take care of it or get it assessed a little bit further. If you're having any type of shoulder problem, or you've had a history and there's this little bit nagging stuff that doesn't really get me to go to my doctor, but it's there, I can deal with it, I will get it looked at. So what are some of the treatment options for a rotator cuff tear, right? You can get a cortisone injection, which you probably heard a lot of people have gotten a shot. And if there's a lot of inflammation in the joint, that affects the quality of the motion. And so a cortisone injection can dramatically dampen that and get it to go down. And then a lot of times the quality of motion can get better, and the tear might scar in a little bit and be in a state where you can use it and do well. I just showed you some data that showed you can have a partial rotator cuff tear and be asymptomatic. So if you do something that causes a tear, cortisone injection is an option, right? Surgery is an option, but that's usually after the conservative treatment fails, right? You tried some anti-inflammatories, you tried maybe some therapy. That didn't work. You tried an injection with some therapy. And so we see people a lot of times that get an injection, say, hey, go do some therapy now. And then they can really start to progress a little bit. or, they just come to therapy because it's not too bad and we can help them work through that. And they just take some oral anti-inflammatories to calm some of that stuff down, and we can restore good quality of motion. But that's where physical therapy comes into play. As I mentioned before, you don't have to walk on your hands like you do your knees and your hips. So we can control the variable strains that goes through the arm. And a lot of times we can help you make a substantial improvement unless there's that full thickness tear, or there's a substantial issue with like a labral tear that really is affecting, your joint locking up and catching on you. So what are some things you can do to relieve some of your shoulder pain, or some of the things we do in physical therapy? At least if you do go to therapy, I would expect wherever you go that they're putting your hands on you a little bit. Yes, you might be weak, but unless you have full motion in all directions, expect a little bit of hands-on care. That's something we emphasize and I emphasize in my clinical practice. But wherever you go, if you do need some shoulder stuff, the research shows that if you get some hands-on soft tissue work, stretching, in addition to the training, people get better results than just hands-on and nothing else, or just exercise and nothing else. So be an educated consumer. If you go with some therapy, expect to get some of that, or at least ask for it if you're not getting it. And so I do a lot of hands-on work. I work on those muscles because there are so many muscles that affect it. And unfortunately, in the shoulder, when you go to reach or do something, you don't usually feel a stretch in the shoulder like those small little muscles. You feel a bind or a pinching in the shoulder before you'll feel an actual stretch in those small rotator cuff muscles. So a lot of times there can be some tightness in them, and we got to work them out, and we have to do it through a little bit of soft tissue work, as opposed to being able to just get big stretches and you feel this big pull in your muscle like you could with your thigh muscle or your hamstring muscle in your hip area. Again, rotator cuff strengthening is pretty much a staple. That picture on the right is a standard rotator cuff strength exercise for the backside of the rotator cuff. The middle picture shows some stretching, right? People would use pulleys. And we use things like pulleys to stretch it out, also to assist with quality of movement. And I tell all my shoulder patients that it's not how much you do, it's not how much weight you lift, it's about having good quality of motion. So if you're hiking your shoulder up to lift up like that, the quality is not there, and you're going to end up continuing to irritate yourself. We can find ways where if you slide your hand on the wall, or you use pulleys to help, or we find alternative ways like laying on your stomach to do some exercises where your shoulder moves like it should, you're going to have a much better chance to be successful. And a lot of times people say, well, just hold your shoulder down and reach. Well, it's not that easy. Otherwise, people wouldn't be hiking their shoulder up. So we've got to find alternative strategies to find exercises that are critical to the individual to do. So this is a picture of a few different examples of common shoulder strengthening exercises that you might run into in physical therapy. This is not, hey, if you have shoulder pain, you need to be doing these. Again, I'm just giving you some examples. This isn't something you should just go do and assume that it's going to fix your shoulder issues. I would want someone have assessed your shoulder and give you specific ones, but just to have some examples of what you would do. The picture on the left is working one of the rotator cuff muscles. The picture in the middle is doing some exercise where it's working on some of the shoulder strengthening and working the top rotator cuff muscle. And the one on the right is working the back rotator cuff muscle. Next slide. Again, we do a lot of exercises sometimes with patients on their stomach because the forces of gravity are different and the shoulder can function sometimes better here. And so this shows a couple different examples of that, where you're training your shoulder blade muscles, you're training some of your rotator cuff muscles here, you're training your biceps with like the row. We talked a lot about that ball and socket, but it's just important to have great strength in those shoulder blade muscles. And typically that joint, the shoulder blade movement on the rib cage, isn't an area that people actually have a lot of pathology or problems with. So we can get those muscles stronger. And if there's tightness there, we can stretch them out. So, getting you, especially if you have poor posture, we want to really work hard on getting those shoulder blades back and strengthening those muscles, because the majority of people have tightness in the front side of their shoulder and their pectoral muscles And that pulls that shoulder blade into like a tipped forward position on their shoulder, and it makes them more likely to get that impingement where there could be rubbing on the rotator cuff. So, that's one of the foundational things where we start with is get your shoulder blade stronger, get some of those muscles better. And that usually leads to some improved posture and a better ability for your shoulder blade to move on your rib cage. And ultimately that means you can reach your hand over your head with less pain usually. As I mentioned, stretching is still a part of it. If you don't have good range of motion, that means that you could be binding up that shoulder. All are just some examples of some ways to stretch the shoulder with the pulleys reaching across your body, or that top left position where you're basically the patient's laying on their shoulder blade so that it stays stable when we're trying to stretch some of the stuff in the ball and socket. My disclaimer with any type of stretching that you would do, whether you're in therapy or whether you're doing it yourself, you always should feel more stretch than pain. If you're feeling more pain than stretch, please don't do it. It's not helping you. It's probably throwing fuel on the fire. It's probably causing more irritability than not. And if you don't know the difference between what like a stretch is and a pain, find an area that's not hurting, whether it's your forearm and you're just stretching it like this, or your hamstring or your quad. You should feel a gentle muscle pull, and it shouldn't be painful if you're stretching. If it is more pain than stretch, find an alternative way to do it or ask for somebody for help, because it's probably just going to aggravate your shoulder. Next slide. These are some examples of some other ones. The one in the middle there is showing somebody stretching their pectoral muscles that I just mentioned earlier that can get tight, and everybody has a doorway. Again, this stretch on somebody whose shoulder can be painful sometimes actually causes pain. So it needs to be a stretch if somebody does this at home. And those are the questions that like I ask all my patients, like, do you feel a good stretch? And when we're stretching, we always hold stretches in general, for 15 plus seconds. That's what really elongates the muscle and keeps it a little bit longer afterwards. Otherwise, it just kind of like a rubber band. It just stretches out and it goes back to its original length. Now, the two pictures on the top show somebody using some sort of foam roll, but they're addressing some of the stuff in the thoracic spine or the rib cage area. And why is that? Well, the rib cage on the shoulder blade is part of the shoulder, how it moves. And so if the rib cage in the thoracic spine can't extend, then the shoulder blade can't tip back like it normally should. And that affects the quality of motion in the shoulder. And that makes you more susceptible to having issues when you're reaching overhead, when you're reaching with that fully outstretched arm. So some research shows that if you improve the thoracic mobility, you can improve reaching over your head by 10 or 15 degrees without even touching the actual ball and socket joint, right? Just by improving the thoracic motion. So if you've got some shoulder issues, it's always important to make sure that you have good thoracic mobility. Next slide. And so the other thing that you'll see, or that you should see, like I mentioned earlier in therapy, is some degree of hands-on care and some degree of strengthening, stretching exercise. I work a lot on the muscles of the rotator cuff. I work a lot on the muscles that attach from the shoulder blade to the neck, to the rib cage, because there's undoubtedly some areas usually that are tight and that can get a little bit better. And our body is good at compensating. It does it automatically. Our brain just finds the easiest way to get stuff done. And when it does so, it ends up over recruiting one area, and that muscle might be, just tight all the time because we're working it. It might be tight just because it stress other things, like the top right picture is an area that a lot of people get tight in, that upper trapezius area that a lot of people's like, oh man, my shoulder, my neck, it hurts right there. It's tight. That can cause, that muscle also helps move your shoulder blade. And so if that's not functioning right, if it has issues, it needs to be addressed. The picture on the left shows a little bit of mobilization, right? So we also sometimes, if the joint is a little stiff, it's our job to help mobilize it, where we stabilize the joint partners and try to mobilize a little bit. So manual therapy with joint mobilization and massage are a big part of the care that I give to my patients that have shoulder pain or neck pain as well, because all that stuff kind of, they have muscles that cross over between the two. So again, how do we avoid needing surgery, having to get injections? Nobody likes needles, or having to use excessive use of medications for pain. like I said earlier, try to be proactive, right? Don't wait till it's terrible before you go see somebody. Make sure you have a good team, right? Make sure you have a good primary care physician who will listen to you. Or if you can go directly to a specialist, if you can go directly to a specialist with your insurance, maybe you go directly to a specialist in that area. Seek out providers you trust, whether that's, you have a good physical therapist or, physician and massage therapist, whoever that team of people that work with you to kind of work through it, develop a team of people. Ultimately, then you have multiple people that are looking at your shoulder and or other issues you have going on and can give you their objective feedback. And sometimes it's good to have a couple different people that have their different perspectives into it. And then ultimately, conservative treatment, and that's what physical therapy is. It's a conservative treatment, typically is where insurance wants you to start, or I think you should start. Getting an MRI usually is more something that dictates, do you need surgery and where that area is. An MRI doesn't fix you. X-ray lets you know maybe if you have arthritis and what we're dealing with. They do those things if they want to rule out something like cancer or a tumor or those type of things. But usually your physician or somebody would recommend that you try something like physical therapy first for at least a couple of weeks of it, see if your pain can get more controlled. And if we're unsuccessful at that, then they usually go down the next step to some of those other things. But a lot can be done, I think, particularly in the shoulder, without needing to necessarily take really aggressive medications or some of the other things. There's definitely a subgroups of people that will need surgery, that will need injections, and that will need medication. But typically, if that's the first step you go and you don't try some other stuff, surgery can always make things worse, right? I let my patients know when I think they are a surgical candidate, but there's no guarantee that surgery makes it better either. So that was all the information I had. We've definitely got some time here to answer some questions. And so I know Karen's been seeing some questions come across to her. So I'm happy to open up any questions that people have.
All right. Thank you, Matt. That was excellent. A lot of information. So going back to your question to the audience, we have a lot of input. So I'm just going to give you kind of some of them about what type of pain they have, what problems they're having. So
Sure.
Limited overhead reach with pain, and pain when I stretch across my body, hurts when I lay on my left side. I have quite a few people who it hurts when they lay on, like if they lay on the left side, the right side hurts.
So those are some good points, and I can address that with sleeping. I mean, if your shoulder hurts a little bit, usually it sucks to sleep on that side. Most of my patients say, like, if they can start sleeping their side, I know their shoulder's getting better. If your shoulder hurts, even when you sleep on the opposite side, a lot of times your arm gets draped across your body a little bit, and it still jams a few things, jams the labrum and some other stuff. And so it can be difficult still. They call it the beach chair position, or the kind of your arm rested up like you're laying in a beach chair where it's forward and out to the side a little bit. That's usually the position of comfort. So if somebody's laying back in a recliner, their arms up like that. A lot of our shoulder patients, like after surgery, they sleep in a recliner because that's a position of comfort they can let it rest in. But if they let it go all the way to the bed, laying in the bed, they don't do well with it. So I'm not a big fan of sleeping in recliners for people, but if it lets them sleep and they can get more sleep there for a short period of time, that can work. Usually a body pillow, if you're trying to lay on the opposite side that hurts, a body pillow or something to support you so that your arm doesn't fall across your body works well.
I do that. I have that issue, so I have an extra pillow I just put underneath my arm at night. So it makes a great deal of difference. It actually helps my neck pain. I have neck pain when I do that, so that helps my neck pain. Pain in the front of the shoulder radiating into the bicep with limited reach behind the back.
Right, and that's a common thing, and that that could be something that's we talked about. The biceps has some attachments into the labrum. So people can have just a biceps tendonitis. I didn't use that on the list of the top 4, but that is something that falls into the next couple that we run into where somebody has just a biceps tendonitis. That will not feel good to reach behind your back, or when you're reaching in front of you out there, that's one of the things that will stir that up. So again, I'm not saying that's what it is, but that would be the something to get looked at, right? You know, how is the function of your biceps, and the pain can radiate into that region if there's potential biceps involvement.
Okay. Burning pain and constant tightness in the trap muscle.
A lot of things can affect that. That's a Pandora's box a little bit, because that can be stress, that can be neck stuff that can get you into there. That usually does warrant some good somebody with a good skill set to look at it, try to figure out what that is. If you're finding yourself hiking your shoulders up a lot, or a lot of mouse work, even on one side, you're always got that on a little bit, right? So if you're using a ton of mouse work, even when you're not lifting a ton, it's on, right? So if I told you to hold your coffee cup and I told you to do it for an hour straight, your biceps would be burning and achy and things like that. So that same type of thing can happen if that muscle is slightly on all the time, especially if you're not doing lifting, reaching, and a ton of other stuff with it. So that's how I try to explain some of that stuff too. If it truly is just like a muscle thing, and that's where it goes back to, a lot of times we look at things like that when people have that on their posture. Do they have that slouch positioning? And then you also, you want to train opposing muscle groups. So let's say when you kick your biceps in, right? When you bend your elbow, your biceps has to kick in. But your triceps, the muscle on the back of your arm, has to relax. So if a muscle's always on, it's good to train the opposing muscle, right? So there's an upper trapezius that helps you lift up, and then there's a lower trapezius that helps you bring it back and down. And so we work on those type of things a lot of times with patients that have pain in those areas, because that helps turn off that muscle, right? We said if it's turned on a lot, we want it to turn off, right? Stress can make us do this. We tense while we're driving if it's rainy or whatever it is. Or I see it a little more sometimes even in the wintertime, right? For people that have neck pain, I say, wear a scarf, because we walk around like this in the wintertime when it gets cold, right? And that doesn't help, because our neck starts to extend a little bit, and we're trying to not let the cold air get us. And that can actually, perpetuate some of the already pre-existing issues going on.
There you go. One more reason I don't like winter. Popping and grinding. So I know you talked a little bit about this. Do you want to say anything more about popping and grinding?
The grinding, and if it sounds more like that, and it kind of shifts a little bit with you, that can be a sign. Again, can be a sign of some osteoarthritis. If it pops a lot, that can be just the joint moving. Like, I can pop my knuckles. It doesn't mean they're arthritic, right? That can mean that you have a lot of mobility, and your joint can pop when it kind of moves, and it's a pressure change. Like kind of popping, locking type of thing could be potentially that, labral issues as well. But if it makes a lot of kind of grinding noises as you reach up versus, well, every time I reach across my body, I feel a pop. Well, that could be more just like one of the joints getting a little excessive movement.
Okay.
So I tell people, look, if you get a little popping in your shoulder, like I can make my AC joint pop when I go all the way overhead, but it doesn't hurt, and I don't do it 100 times in a row. If I did it 100 times in a row, it might make them get irritated. If your joint pops a little bit and doesn't cause any pain, and it doesn't do it every reach you do, let it lie. I think that's okay, right? That's what I tell my patients. Like if it hurts or it's making you move different, then I think you should address it. But a lot of people's ankles will pop, their shoulders will pop, their joints pop because they might move a lot. And that's not that abnormal, or like, oh my gosh, I have to rush to the doctor because there's some popping. If it's popping and it's painful, get it looked at.
So we had one person say they're a side sleeper, and when they get up in the morning, both shoulders have shooting pains when they first get up. That goes, it eases. It doesn't say it goes away, but it eases up after a while. Right seems to be a little worse than the left. So I'm assuming that's something someone should see somebody about.
Yeah, and there's you have to rule out, when I look at someone's shoulders that have shoulder pain, I always have to look at their neck as well, because there's a lot of referral patterns from the neck that can make you feel pain between your shoulder blades, that can make you feel pain in the outside of your arm, that can make you get pain down into your arm. And so they can very much mimic a shoulder pathology when you have a subtle nerve irritation or subtle neck issue. And so, or they are concurrent with a shoulder issue. The rotator cuff is innervated, meaning it's getting signals to fire and work from the neck, right, from the nerves. And so if there's an issue there, it can affect the ability of the rotator cuff to function as well.
All right. All right. So William has a question, and you answered them when you had the pictures of exercises. And I know when you were with us back in March for the back pain, you referred folks to a website for exercises. And I think we have that. And I've asked Karina to put that in the chat and maybe as a banner. It's on the Run a Show, Karina. And for people to find, it's sort of like a symptom checker was one website, and the other was the exercises. So they can find that there, I'm assuming, those kind of exercises, correct?
Yeah, I think the Move Forward PT website, I think if that's what the one we're referring to, was some good information about general diagnosis, this type of thing, and with some information on some general exercises for that type of stuff. Again, I always caution people a little bit if they're self-diagnosing things. Like I said, there's not a one-size-fits-all exercise group, and this comes back into my ideal world would be that people, just like you go to your dentist once a year, you get a yearly musculoskeletal, or you get a yearly screen of your teeth, and a lot of times the insurance pays for twice a year to do that, so that you don't run into cavities or whatever else it is. And you go see your physician for your annual physical. That and depending on the physician, annual physical, musculoskeletal wise, it isn't really in depth, right? And that's fine, because they got to look at everything else, your blood work, how everything else is going. But I think an annual musculoskeletal screen is advisable for people, and all physical therapists should be able to do that for you. You can bill for usually an evaluation to insurance companies and do that. There's direct access in Michigan, here at least in Michigan, and in most states, some form of direct access. So I would encourage people to try to do that, right? Proponent of getting it looked at and getting someone's eyes on it that are aware and can screen through that, especially if having issues with shoulders. So I would say that would be something you would do if you've got some of that stuff, and then make that a routine thing, because I think that would help a lot of people work through some stuff and get a baseline, right? Like, hey, how tight am I? Like, how is my motion getting less year over year? Do I not score as well? Or if I do, looking at general, like, hey, I can't touch my toes anymore, can't do some of these other things, oh, I didn't really realize that, but yeah, I am losing some flexibility based on when you looked at me the last year. I think those are good baseline things to have, and might be good drivers that people need to do something a little bit more, or just to kind of keep themselves at a good baseline.
And it's a great suggestion, because we know that when we go to Dr. Google, we always get in trouble. It's like the worst case scenario, or we're thinking it's something different than it is. So, and you can see on your screen, they have put up a couple different websites. One's a symptom checker, and then the other is the exercises. So Susan asked if an MRI is the only way to tell if you have a labral tear, and you kind of talked a little bit about that, but I wasn't sure that you actually,
Sure, yep. So on the gold standard for diagnosing labral tear is MRI arthrogram with usually an injection. They'll actually inject a dye to get a little better. Like, that's the gold standard for it. You can still see labral tear if you have an MRI, but MRI shows the soft tissue structures, where you would not be able to tell if you have a labral tear just based on an X-ray alone. Obviously, we correlate that with what the bedside exam looks like, right? Do you have some other special tests that typically are indicative of a labral tear? But before anybody would ever do like surgery on it, right, they would want to probably have an MRI to confirm those type of things.
All right. Poppy asks, what part does diet and exercise play in preventing or managing shoulder pain?
So, good question. I think diet and exercise, can affect other joints a little more if we're talking about weight management, things like that, right? So knees and hips, right? You lose some weight. If if you lost some weight, that takes load off the weight-bearing joints of the hip and the knee. Again, like we mentioned earlier, the shoulder is not a weight-bearing joint. So, I mean, yes, you can get on your hands and knees, you can do things like that, but it's not loading weight all the time. So it never hurts, right? In regards to, good quality proteins in. If you're trying to get stronger, right, you need to have good fuel sources in, right? You need to be, adequate, intake of water and those type of things to stay hydrated, and in general for your muscles and tendons and things to be healthy and work. And if you're exercising, a lot of times you're exercising, you're in better postures, right? And you're doing things where you're upright, and when we stand, our posture is always better than when we sit, right? So if you're exercising, hopefully you're working on things that are good for posture, which is going to be good for the shoulder. So I would say it can correlate with better shoulder health just because you're upright and you're working on better posture type of things when you're exercising. But if you were to say, if I can just change my diet to help my shoulder out, I would say that you might be able to help a little bit, but you're eating an anti-inflammatory diet or whatever it may be, things like that. But I think exercise has a better chance to help out some of those things.
Okay. All right. There's a couple of questions that are very similar, so I'm going to kind of combine them. It gets at what kind of time span does it take to feel better after you've had either surgery or, an injury, and
Sure.
And I'm guessing it really depends on how bad the injury and things or surgery.
Right. In general, surgery, when they're repairing a rotator cuff, there has to be a period of time where, or repairing a labrum, there has to be a period of time where it heals in, where you can't do a lot. So that first 4 weeks is usually pretty low key. And then the next couple of months is where you can start doing more. So it's usually the neighborhood between, 3 and 5 months, to get fully back with some stuff, and usually not back till up towards a year for shoulder surgery. In just a strain or something, it could be, if it's just a light strain and you didn't do anything, it could be, a couple weeks that you're back at it. If it's, you can't lift your arm and it hurts really bad, and, typically then you're talking, maybe it might take, 6 weeks for you to be moving that direction. What I tell people is that if you go 2 weeks and you're still struggling, get it looked at, right? I mean, if it was just, oh, hey, I did something, because yes, things will get better with just time, right? Time will be your friend a lot of the times. But if time isn't in conservative management, like you're resting it, if you took a little ibuprofen or something like that, and it's not getting a little better, then get it looked at if it gets beyond that 2-week window.
All right, we just had a couple minutes, and I have 2 questions I want to make sure you answer. One is, after you are pain-free, you've completed PT, you're pain-free, how often and how long should you continue to do the at-home exercises?
That's every day, all day. No, I'm kidding.
Forever.
I tell this to my patients, right? Because they're like, oh my gosh, is this a sentence I have to do 3 times a week, these exercises, like I was coming to therapy? I said, look, if you got stronger, you can, once a week will maintain your strength. Doing some sort of exercise once a week will maintain strength. You got to remember that day-to-day activity is exercise too, right? If you're putting stuff away, if you're lifting things and you're folding laundry, some of that stuff is still exercise for your shoulder. So once a week of some exercise that you were given in PT should be enough to maintain the gains you've gotten. You can stretch every day if you feel like stretching feels good. That's fine. But doing strength training once a week after you're done with the course of therapy usually should be enough to maintain the gains you've gotten.
Okay. All right. Last question. How do you select, Edie wants to know, how do you select a good therapist when your primary care or hospital have no recommendations? And I've asked Karina to put in there you go, on the screen, there's what you gave us before about how to find a PT. And so if you want to talk about that for just a second.
Right. Not every physician will recommend one place or another. I would talk to some of your trusted friends a little bit, because if they've experienced therapy, I think that's one of the best ways that people recommend to come see us. So they've had a good experience. They know they've had it firsthand whereas maybe a physician hasn't been in your facility seeing me firsthand, right? So they don't have the firsthand experience. It's through secondhand reports from patients or whatever it may be. So try to talk to somebody with a firsthand experience that's local in your community. You can obviously go to places like that. You can search if somebody has potentially additional certifications, but that still doesn't guarantee that they have, will treat you well. But all therapy clinics in an outpatient setting should have plenty of experience in the shoulder. But I would talk to some of your friends. And if you're brand new to an area, then I would call a couple of facilities and just ask about how a treatment session would be and that type of thing. And just, you'll know by some responses probably which place is going to treat you better. So
there you go. All right. Well, we're out of time. So and there are a whole bunch of questions still that we didn't get to. So I apologize to the audience for that. But thank you for all of your great information. And for the audience, if you want to look at this again, watch this again, or recommend it for somebody else to see, you can watch it right afterwards on Facebook, or you can go to the AARP Michigan Virtual Events page, and you can see you can see this one, maybe not immediately after, but in about a day, and I'll see what's coming up for events in the future and see the recent past on demand. So thank you, Matt, so much. Really appreciate having you again today. And goodbye, everybody. Have a great afternoon.